We are live.
Very good evening, everyone. Welcome to iFocus Online, episode 341. It is number 16 in the module of Oculoplasty. Today, it is an honor and a privilege to have Dr. Milind Naik, sir, from Prasad Eye Institute, Hyderabad, talking to us on injectables and fillers for periocular aesthetics, indications, outcome, and complications. I think sir doesn't require any introduction, but just as a formality for our audience, I will introduce him. Sir has done his MD ophthalmology from CMC Vellore and fellowship in orbitofacial plastic surgery from UCLA, Los Angeles in 2006 and 7. His current position includes consultant department of ophthalmic plastic surgery, Prasad Eye Institute, Hyderabad, and adjunct associate professor, University of Rochester, New York. He has been a recipient of many awards, the foremost which includes Senior Achievement Award, American Academy of Ophthalmology. He has been the Vice President of Asia Pacific Society of Ophthalmic Plastic Surgery in 2010 to 2012. And he has also been included in top 2% of the global researchers in ophthalmology from the Stanford study in 2020. His main areas of interest include eyelid and orbital surgery, aesthetic and facial plastic surgery, thyroid eye disease, and minimally invasive ophthalmic plastic surgery. He has almost 238 publications, peer-reviewed publications, and presentations are over 500 in national and international conferences. And he has been on the editorial board for the Journal of Cranio-Maxillofacial Trauma and Reconstruction, Korean Journal of Ophthalmology, Journal of Cutaneous and Aesthetic Surgery, and Indian Journal of Ophthalmology. A very, very warm welcome to you, sir, and over to you. We're eagerly looking forward for your lecture.
Thank you, Shefali, and thank you, iFocus. Thanks to Dr. Santosh for having me here. Let me just share my presentation. All right. Are my slides visible?
Yes, sir.
Okay. Is it in the presentation mode? All right. Okay. So, as per the topic, we will talk about injectables, and we will stick to the periocular region. So when we think of injectables, we might think of multiple things, but here we are going to focus on primarily two things. One is the toxin, and I'm purposely using the word toxin to avoid the trade names, and the filler. And both have functional as well as cosmetic uses. And we will stick to the cosmetic uses for today. So the theme for us is not really to talk about the basics like chemistry, reconstitution, etc., which you can read in the textbooks. Neither are we going to talk about spasms or other functional uses of fillers. What we will focus on is the aesthetic applications of these and how to get things started if you are a novice in this area, and mainly practical tips for the residents as well as the fellows. So let's begin with the botulinum toxin. I know that this is popular for its functional uses in ophthalmology, which is mainly spasms. But when you come to the aesthetic side, many people are just aware of the fact that they are used to treat wrinkles. But that is just one of the use. And the second and very popular use is facial recontouring, where you don't really focus on the wrinkles, but you try and change a feature of the face just by tweaking certain muscles with the botulinum toxin. And we'll come to that. But first, let's talk about wrinkles. So in the periocular area, there are 2 or 3 very popular treatments, and one of which is to treat the horizontal forehead lines. Now, these lines are not necessarily bad in any way, and they don't require treatment in everyone. But those who perceive that as a sign of aging, we could relax the frontalis muscle, which is below the forehead skin, and thereby reduce these lines. So here is a picture of a male patient, middle-aged, trying to raise his eyebrow on the left side, where you see these 2 prominent lines. And here he's trying to raise it. This is post-botulinum toxin, where you see those same lines, but they are very faint here. So obviously, over time, these dynamic lines can turn into static ones. And if you were to treat them regularly with Botox, maybe from the age of 35 to 40 years of age, then probably you're also going to delay the appearance of static lines. So when you treat the patients for horizontal forehead lines, remember that we are not injecting or treating the lines, but we are treating the muscle below it. So our goal is to treat the frontalis, which in many patients is a single sheet, but in some patients there could actually be two bands on either side. So you have to look at the contour by asking the patient to raise their brow multiple times and treat mainly the central area. The areas that we avoid in these is lateral to the junction of the medial two-thirds and lateral third of the brow, so somewhere here. Beyond that, if you inject, particularly in a female, then the tail of the brow is going to come down, which they are not going to like much. Secondly, within a centimeter of the brow, you don't want to come closer to avoid brow ptosis. And you obviously don't want to go very close to the hairlines. So you try and eyeball which area the lines are mostly prominent in and treat them as such. Crow's feet is another popular area which is treated. Again, I would say that this doesn't look bad in everyone, but there are certain patients and take this as a sign of aging and they just want to get this treated. It's a very straightforward injection where you go a centimeter would be your first spot. Obviously, you need to eyeball what is the extent of these lines. They sometimes can fan all the way up to your hairline. In other patients, they are just crowded near the lateral canthus. So one spot lateral to the lateral canthus, maybe a centimeter, and the second one just below it, inferior medial. You can also feather a little bit of Botox into the mid-pupillary line in the lower eyelid, just so that you also iron out the lines which are in the medial part of the lower eyelid. The spot above the midline, which is mentioned many times in the textbooks, can be closer to the lacrimal gland, and we'll come to that when we discuss complications. So here are clips before and after the injection. You can see that the creasing along the canthus has reduced post crow's feet injection. These are never done in isolation. This is always done as a treatment for the overall face. So you treat multiple areas with Botox, sometimes Botox and fillers. And crow's feet is just a component of it. Here I'm just focusing on that area to show you the exact way of injecting and what to expect. Here is another lady. You can see actually her smile is wider post Botox injection, and you don't really see as much lines as you were seeing in the pre-op area, in the pre-injection video. The second one is frown line. Not every patient is bothered by the line as such because it's a dynamic one, but some of them are just bothered by the expression. Some professions, you're not supposed to be looking angry or upset, and these patients may just want to look pleasant all the time. So how do you do this? These frown lines are created by the corrugator supercilii, which is a muscle which fans from the midline outwards towards the body of the brow and pulls the brow medially. So you form these vertical lines. So here, what you can see me do is to inject this entire body of the corrugators. There are 5 points marked, and my non-dominant hand is actually placing the thumb on the orbital rim so that I know that I'm placing the drug above it. This is particularly true in middle-aged and slightly older people where there could be brow ptosis and you might be injecting closer to the levator. So here is the same lady. In both photographs, she's trying to frown. It's a dynamic finding. I know this is a photograph. And you can see that the frown line has reduced. It hasn't really gone away completely, but it has softened. Coming to facial contouring. So here we are not really targeting the lines, but we are trying to change some feature of the face. For example, here, where you have the aperture of the eye completely closing when the person is smiling. How do you improve this? So you can improve this by giving just 2 or 2.5 units of Botox in the mid-pupillary line in the pretarsal area. And here she is with the same amount of smile you can guess from the nasolabial fold, and the aperture stays wider. One can also add a similar area in the upper eyelid if you want to make it further wide, but that can lead to slight lag of thalamus. And this is often erroneously called as hypertrophic orbicularis. It really isn't. It's a prominent orbicularis role, oftentimes mistaken as a fat bag. The second popular periocular contouring change that you can bring with toxin is a chemical brow lift. So you can actually change the shape of an eyebrow by tweaking two muscles. And I'll just explain that with this simple video. So if you have this position of your eyebrow hair, if you were to give these 4 to 5 points in the center and relax the frontalis muscle, the head of the eyebrow will come down. And laterally, if you relax the orbicularis, which pulls the eyebrow down, the tail will get raised. So this is how you change the contour of the eyebrow. And if you look at surgical principles of blepharoplasty, where you also want to do a slight eyebrow lift, we tend to remove the orbicularis in the lateral half of our blepharoplasty so that the frontalis gets an unopposed action and the tail end of the brow comes up. It's a subtle benefit, but it's worth adding it. And we are achieving the same thing by giving botulinum toxin to those specific areas. So look at these examples. All these results are very subtle, but you can notice the change in the shape of the brow caused just by relaxing the frontalis and raising the tail end of the brow by relaxing the orbicularis here. And this amount of units that I use, 1 to 2 units, is really not going to cause lag of thalamus. Going a little bit beyond the periocular region, this is lower facial contouring, and this is really a functional case. This was a case of bruxism, and you can see this lady has this bulk on one side. Initially, we even thought that this could be an enlarged submandibular gland or a parotid gland, but when we did the MRI, we found that the masseter on that side was thicker. And what did we do? We injected Botox into her masseter just on that side. And here you can see the results post Botox injection. Entirely a functional case, although it had a cosmetic component to it. But you can see the rounding of the contour, the shape became more symmetrical, although she has a relatively squarish male kind of face. The same philosophy can be applied to females who are bothered by a squarish face. So what you do here is to treat the masseter muscle on either side. The units that are used are slightly on the higher side. It could be anything between 25 to 60 or 70 units per site. And we can inject it either in 5 spots or reduce it to 2 or 3 spots at the lower edge of the masseter. So here she is before and after the injection. You can see a very gentle and subtle softening of the acute angles that you see. Similarly, in side view, there is a softening of the acute angle of the masseter. Obviously, if you add more, you're going to get a higher benefit without really affecting functions like mastication. Another common popular area for Botox use is gummy smile. It doesn't always look good on everyone. Here is a smile where the gums are visible, and especially if they are pigmented, then it can be a challenge. What do you do here? So there are 2 muscles which lifts the lip in excess. One is the levator labii superioris alachinesi, and here is the levator labii superioris. So both these muscles can be targeted if you inject just 2 to 5 units of Botox inferomedial to the nasolabial line. It's actually the same spot that you would use when you're treating hemifacial spasms. So here she is post-toxin. You can see that the lip isn't lifting as much, despite the fact that the smile is the same. So this is another important facial indication of contouring with the toxin. Let's talk a little bit about the filler. Now, this is the same hyaluronic acid that you use in your intraocular surgeries before you place an IOL, just that it's cross-linked. And if you look at the theories of aging and you oversimplify it, there are three causes. One is sun damage, second is deflation, and the third is descent. So for sun damage, we have our dermatology friends who take care of the skin care. For the soft tissue descent, we have surgeries like lifting, it's eyelid lift, brow lift, and so forth. But for deflation, we have to augment volume. And for that, fillers and fat are the two options. So here we'll talk about the fillers. And in the periocular area, the commonest indications are brow filling and the tear trough. So let's talk a little bit about the brow. As we age, medially you would tend to see a bulk. Look at this middle-aged lady on the other side, on the right hand. This is the medial fat pad. Now it appears as though it has increased, but it has just prolapsed out because the tissues are not able to hold it back so well. But in the center as well as laterally, you actually have collapse of volume. Now this is the subbrow fat pad, which reduces with age, and it causes an excess looking skin fold, which sometimes can even be called as pseudo dermatochalasis. Here is an example, thin skin fold, to the extent that these patients read a little bit online and they come and say that I want a blepharoplasty. Many of these borderline early cases can actually be solved by filling the brow. This filling can be done by a filler or a fat injection, but here we have done it with a HA filler. You can see that the actual fold of skin or the line has absolutely disappeared. This was done in 2 sessions. And how it is done, it's done under topical anesthesia. You just go into the subbrow fat pad just above the periosteum. But mind you, it has to be beyond the orbital rim. So you're not really crossing the orbital septum. You go beyond the rim and inject. So your non-dominant finger can actually guide you in such a way that you don't inject this into the orbit. So once you place a bolus there, you can actually press it against the supraorbital rim and spread it out, or you can inject it in 2 or 3 areas. So this is the same lady whose photographs I showed earlier. You see the filling of the brow and no more requirement or perception of a need for blepharoplasty. Similarly, this patient, apart from her brow, we injected filler in multiple areas, also the temple. You can see the hollowing of the temple is reduced, but focus on the absence of this excess lid fold in the upper eyelid. You can see it in the side views too. Coming to the tear trough, this is a natural groove that many or almost all of us have, less prominently so in young age, but sometimes it could be a familial thing and you could have it pretty much in young age. But as we age, this tear trough becomes more prominent, and this could be perceived as a sign of looking older or at least tired. These are examples of tear troughs which are filled with a filler injection. And how do you do that? So here is the basic philosophy. Normally the contour from the lash to the rest of the cheek is flat, but if you have a hollow in between, you are basically injecting these microparticles of filler just in front of the orbital rim where exactly the tear trough is. You're placing it just above the periosteum, deeper to the skin and orbicularis plane, to actually flatten out that groove. So this is how it would look after the filler injection. And the same is applicable for a fat injection. So if you read about filler injections, they're mostly described to be done under topical anesthesia or sometimes just cold application. And the technique of injection can also be either a needle injection or a cannula. Cannula is supposed to be safer. We'll talk about it when we discuss complications. But here what I'm doing is point bolus injection. So I injected in this area and then laterally. And now with my finger, I'm just spreading it into the tear trough. There is also a linear threading technique, which is described, and you can also do a crisscrossing. But the more number of times you pass your needle inside, the higher are the chances of poking a vessel, causing bruise, and entering the material directly into a vessel, which can lead to vascular complications. So I personally prefer to just inject bolus in 2 or maybe 3 areas. And that's about it. And the rest of it is done as spreading with your finger. So here are some of the examples of tear trough filling before and maybe 2 or 3 weeks post-injection. Many of these are young patients. You can see the tear trough disappearing, and you can appreciate the fact that just that disappearance of the tear trough makes them look more fresh or less tired. Here is another example where she's almost 14. You can see that the tear trough is also extending laterally, which could be treated with the filler itself. Here, the tear trough wasn't really much, but there was also the squaring of the cheek area. So we also filled the malar region along with the lower eyelid. When you do it for the middle-aged, yes, you can get good results in these two, provided the skin is relatively thicker and they do not have thyroid or fluid retention tendencies. For patients who have a very mild fat bag, or just a gentle one, it can be easily camouflaged by just doing a filler underneath it. This is one example. Here is another example of a relatively young girl who didn't really want blephs for these small fat bags. So we put in filler just below that. So as long as you're able to level everything up from the lashes onto the cheek, you will get a good result. And that is what is an indirect sign to the untrained eye that this is a young person's anatomy. Tear trough with moderate fat prolapse. So in this case, we actually did a bleph first, flattened the elevation of the fat, and then filled the tear trough with a filler. Fillers can really also be used to lift the lower eyelid, although you would prefer a surgery there, but there are cases where the patient might just want to choose something non-surgical. So here was a patient where there was slight lower eyelid retraction, and you can see the bulk here, but it did its job. This little show disappeared after the injection, obviously for a period of 1 to 2 years. There are also indications of fillers being given into the orbit, and this has been reported for sighted as well as anophthalmic orbits. Personally, I have done only one case where I injected fillers in a sighted eye because of the complaint of a sunken eye, and this was with a fully aware consent about vascular injection or vascular complications and even blindness. So here we are giving it like a peribulbar block, and you inject 1 cc to push the eye forwards. And once you're comfortable in the periocular region, you obviously can extend your indications into the lip region, the non-surgical rhinoplasties, and even mid-face filling, and the cheek, as well as the chin area. You can have additional training in these, and obviously patients, when they come to you for fillers and Botox, they tend to forget that you're just an eye doctor, and they would ask for indications all over the face. Leftover material, they would want you to inject in areas where it's needed. So it's really required that you have knowledge of the entire face and do some of these treatments, maybe not as your mainstream focus area. And for all the residents and fellows, I keep saying that if you want to learn how to inject fillers, the best opportunity is your DCR patient. So when you're giving a block, don't just give a block, but notice their tear trough, and whether you're using xylocaine or even some amount of viscoelastic, try and fill their tear trough, learn that anatomy, get to know the feel of the anatomy, how deep is the periosteum, treat it like a cosmetic patient. And so when you'll be really doing a filler on someone, you would feel that it's familiar. I will now talk a little bit about the complications. So there are several complications of injectables, and I've just divided them into fillers and Botox because they are quite unique. So when we talk about injections around the eye, bruising and bleeding is common to Botox as well as fillers. So when it comes to bruise, generally subconjunctival hemorrhage is rare in the hands of an oculoplastic surgeon or eye doctor, but you could sometimes get a call from your dermatology friends that this just happened and what should I do? So subconjunctival hemorrhage just means that their needle somehow accidentally went behind the septum and this is just collected there. As long as the patient's vision is fine, in the photos that they share with you, the pupil is okay, I think it's just about reassurance. But to be cautious in these patients, when you're treating them, always ask whether they've taken their antihypertensive medications on that day, whether they are on aspirin and that was stopped at an appropriate time before your treatment. These things do matter. Some patients are on some vague Ayurvedic or naturopathic medications, which can increase the tendency of bleeding. So keep that in mind whenever you are about to inject. But when you already see a bruise, especially for filler treatments, it's best to stop the treatment because the contours change because of hematoma and you won't be able to do a good job. And ice compresses and maybe even concealers for a while to hide it would be good. Tranexamic is generally not required because these bruises are very miniature. And sometimes the bruise becomes apparent to the patient on the second or third day. So warn them that today you might look good, but the bruise might appear day after. And if you really want to assess, this is really not for ophthalmologists, but a slide for non-ophthalmologists. If during your filler injection, if patient complains of blaring or anything that makes you suspect that there's a vascular event, one way to assess their prominence of the eye is to just ask them to put the chin up and you look at it from the worm's view and see whether any of the eyes is prominent. Now, ptosis is a very common feature of botulinum toxin. And it sometimes may not even be noticed by the patient, but when it is moderate, it is. And brow asymmetry can also be a sign of ptosis. So here, this previous slide actually shows a slightly higher right brow in both these ladies. It's very minute, but it's because of the mild ptosis on that side. So the point to be driven is that sometimes you may not understand that there is ptosis, like for this lady on the left side, but you will know it because the brow on that side is higher. So post-ptosis, post-Botox patients, if they have slightly higher brow, you know that it's ptosis. And because they will not tell you that it's droopy, they will just have some vague complaints like it's heavy, I can't see properly, it's blurred, or I have headache on that side. And there are mechanisms described as to how ptosis happens when you do botulinum toxin injections. Commonest indication when ptosis is likely to happen, I'm talking about cosmetic, is the glabular frown lines because you have the, you're treating the corrugator. Corrugator is a deep muscle. So if you strip off the skin and you strip the orbicularis, that's the septum there. You strip off the septum, now you see the levator. Now the anterior-most part of the levator is aponeurosis, but as you get a little more proximal, that's where the muscle is. So you can notice that the muscle is actually closer to the orbital rim. And the corrugator is right here. This is where you were treating the frown lines. So when you inject in this area, if for patients who have supraorbital foramen, there are chances that the drug goes in and pours itself on the levator. Secondly, there are veins which drain into the orbit, and these veins are also known to carry part of this drug and pour it onto the levator. So this paper in PRS talks about these mechanisms, the preperiosteal plane and also the tributaries of the superior ophthalmic plane. Either ways, you would only come to know about it at 1 or 2 weeks post-injection. And unfortunately, there's very little that you can do apart from hand-holding and just assuring the patient that it's temporary and it will go away. None of the drugs which you would have read in textbooks, like guanipidine, are either available or useful in this scenario. Talking about the crow's feet and the lacrimal gland, we spoke about these points, the 3 classic points that are described. Although I personally prefer only the one which is in line with the canthus and one below that. The upper one, you can, as you can notice, is very close to the lacrimal gland. That's where you would be injecting the second one. And not just intraglandular, but even periglandular injections are known to reduce tear secretions. In fact, for patients who have irreparable damage to the canalicular apparatus, you can actually give this part and make the patient happy. So you would want to avoid this part. There is a publication which talks about the reduction in Schirmer's readings when you do the lateral canthal rhytids. And they do mention that it usually does not suppress tear production, but this is a possible complication. So someone who has a known dry eye is already using lubricants, you want to treat their crow's feet, might as well warn them that increased frequency of the drops will be required post-surgery. Here is a crow's feet injection. We already talked a little bit about this, brow reshaping we discussed. Orbicularis roll and ectropion. A lot of dermatologists believe that if you do this orbicularis roll injection, you can cause ectropion. But personally, I don't see that with 2 or 2.5 units, so you can safely do this treatment. Lastly, coming to blindness, and this is associated mainly with filler injections, or for that matter, anything particulate. So it also is applicable to fat injection. It's also applicable to triamcinolone injections, which is a suspension. And this is grossly underreported, but you can see this photograph, which shows the usual areas which are the culprits. And you can see that glabella and periocular is very high in causing this. The reason why this happens is because of the anastomosis between the external and the internal carotids. And this is what exactly happens. If you inject it into the artery, it goes in a reverse manner along that branch, and along with the blood flow, it can come anteriorly and accidentally get lost into the central retinal artery. So for this to happen, your needle has to be into an artery, which is a part of the external carotid system. You have to be injecting forcefully. That drug has to go retrograde for a while and then get lodged into the central retinal artery. Too many things have to happen at the same time for this to happen. But when it does, it is sudden and there is very little that you could do at that moment. And it's also known for PRP treatments, not just the filler injections. And there's a lot of literature about giving retrobulbar hyaluronidase. And this was always skeptical and looked at with suspicion by many clinicians. And we also try to look at whether this drug really reaches the area where it is supposed to be useful, but we found that it does not help. So as of now, for this blindness aspect, there is really no treatment. Looking at the complications, bruising, just assess vision. As long as the eye is fine, you just have to wait it out. Process again, waiting is an option. You can try brimonidine if it works, that's great and safe, but not phenylephrine. Dry eye, it's best to avoid the upper spot in your crow's feet injections for Botox. Ectropion is overrated with Botox, usually doesn't happen. And for fillers, apart from the uneven feeling, which can require Hyalase, the most dreaded is blindness. It's extremely rare, as rare as a flight crash, but it's important to mention it to the patient when you're treating them with this. So I think I'll stop here, and I hope I didn't cross the time, and I'll be happy to take any questions.
No, sir, thank you so much, sir, and for such a wonderful talk. All the diagrams, the animation, I think it was a mixed audience because we are fellows, we actually deal with these patients, but even the residents are actually logged in and like listening to the talk. And actually plasty and aesthetics, we don't read so much when we are postgraduates, but I'm sure they will definitely, one, obviously get curious and hopefully read more of plasty and like definitely understand it very well with all your diagrams and explanations. So thank you so much. So I'll just take few questions that we have from the portal. First is actually the role of 5-FU around the periocular area for scar modulation. How should we give it and how many sessions would we require?
Okay. Yeah, I know this comes under injections, but and partly it could even come under aesthetics. So 5-FU, the other option for 5-FU is steroids, obviously, triamcinolone, but I find 5-FU to be safer because it's not particulate. It doesn't lead to secondary glaucoma. It doesn't have vascular events. It doesn't lead to deposits. And 5-FU, as far as I know, is available as a 15 milligrams per ml vial, and you could directly use it undiluted. How much to inject is always subjective. It depends on the extent of the scar, but as long as you are able to inject intra-scar, anything from 0.2 to 0.3 cc's, right up to 1 or 2 cc's is possible to be given in one session. It is painful, and post-injection, there is a slight increase in the inflammation first, obviously because of the intervention. And obviously, because you're giving it for a scar, the injection is not very easy, so it has to be pushed in. You could give a kind of ring block with xylocaine before you inject this if the patient is not a very cooperative type, or even a nerve block based on where the scar is. How many sessions? I would give an injection, see them in 6 to 8 weeks, and if required, and if scar is shown to be improving or better, I would repeat it. Typically, this works within the first 3 to 6 months of scar. Beyond that, the scar would have matured and will actually need surgery.
And also, so very commonly we see there's a pigmentation, especially on the cicatrix. Like if it's like a lower lid, like if the scar has become like flat and supple, what should we do for that pigmentation?
So if you have a pigmented scar, it could be either a flat scar or a depressed pigmented scar. In either case, you could take help from a dermatologist to use pigment lasers. I personally do not have much experience with lasers, but as long as the scar is not hypertrophic and your management of the hypertrophy part of the scar is over and it's just the pigment now that's striking, lasers is the next option.
All right, sir. So next one is anatomical landmarks to consider while injecting fillers for tear trough deformity correction. Just a quick revision, probably.
Okay, so check if I can just go back in. So if you were to, is this visible, this photo?
Yes, sir.
Yeah, so if you were to treat this particular patient, you can see that the tear trough is usually prominent in the medial half. If this is the mid-pupillary line, in the medial half, you have the tear trough, which is from laterally, generally does not develop unless the patient is above 40 years of age. So I would typically start in the mid-pupillary area. This is the wider triangular depression that you see. And the relationship of the tear trough to the orbital rim is really variable. It's not fixed that you will always hit the bone in the base of the tear trough. So always palpate, mentally make a picture of where the orbital rim is. If the rim is above your tear trough injection point, then you know that there is bone below, which is going to guide you as to where to inject. But the idea is to go as deep as possible, start at the periosteal level. So if I'm giving with a needle and my point injections, I will start in the mid-pupillary area first, then I'll give a second one here, and the third one would be right at its upper end. So mid-pupillary, upper end, and somewhere in between these two. These are the key points that I would choose. Obviously, if the tear trough is more extensive, you'll have to choose more than one spot. If it is present laterally also, then you have to go along the orbital rim and inject it in one or two areas and flatten it out and spread it.
I think you gave a very good pointer, so that I think when you are doing DCR surgery, one can practice when we are.
Yeah, you could even use a viscoelastic and inject it, because as soon as you take an incision, it's going to come out anyways. So you're not harming the patient, or there's nothing unethical that you are doing.
So next is role of imaging like B-scan while using injectables around the periocular area.
Well, apart from the retrobulbar injection, I don't see any role of ultrasound. It's just going to complicate things. Everything that you're injecting is pretty much on the surface. So if you're talking about avoiding lobe perforation, then it's only considered when you're injecting behind the eye. It's a very rare indication. If you are thinking that you could use that to avoid a vascular complication, ultrasound is not going to be useful, because these vessels are very small, the ones which are likely to cause CRA.
So the next one is, how frequently should the fillers be have to be repeated once we use them for cosmetic purposes?
Well, the company brochure does say that fillers are supposed to disappear in 8 to 12 months, definitely by 1.5 years. But more and more, increasingly, we are seeing patients where the fillers have lasted for 2 years, 3 years, 5 years, or even beyond that. So earlier, I used to confidently say that, okay, your filler will disappear in a year. I don't say that anymore. And this, I'm talking only about hyaluronic acid. So you should repeat it only if the patient liked the first one, and now they are again perceiving the hollows to reappear and want to top up, which could be at 1 or 2 or even 3 years post-injection.
So as the patient ages, his or her face, or maybe if they lose too much of fat, if they are working out just after the fillers, do they need to be topped up? Does it change if you have?
Particularly for sudden weight loss, either self-attempted or post gastric surgeries, you will see that the rest of their health looks great, but their face looks aged because they've lost a lot of face. Those could be right indications for either fillers or even fat transfer, because fillers sometimes may not be financially viable. The amount that is needed and the duration it's going to last for may not work out for every patient. So I would say most of these patients end up receiving a fat transfer, maybe 1 or 2 sessions. But yes, fillers can also be used.
So the next one is, can you take us through the plane of injections of the fillers and the botulinum toxin, sir? I know you have discussed it, but just as a quick revision.
So botulinum toxin, the principle is very clear. You have to relax the muscle. So just below the skin is where you inject in the periocular region. Going back again to this picture. So if I am injecting the corrugators, I have to be deeper, which means closer to the periosteum. But all the periocular injections which are in the eyelid, let's say orbicularis roll or the crow's feet, which is a centimeter lateral to the lateral canthus, just go below the skin and inject. Deeper you go, in order to ideally inject it intramuscularly, you're going to cause a bruise. And bruise in a cosmetic patient is as big a complication as PC rent in a cataract surgery. So you have to be careful about that part. Masseter, of course, is deeper injections when you are doing zygomaticus major, let's say for functional spasm patients. It's one of the deepest injections. Your half cc needle entirely disappears right up to the heart when you're injecting the zygomaticus. So it depends on the location of the muscle. Most perioculars are just subcutaneous. And for fillers, the deeper, the better.
So the next one is, are there any local or systemic contraindications to the use of injectables? One, of course, you discussed about the use of blood thinners. Any other local or systemic contraindications that we should keep in mind?
Systemic, actually none. Earlier, the botulinum toxin products used to be stabilized with albumin. Now they don't have that anymore. So egg allergy is no more a problem with these patients. It is said that if you have disorders of nerve muscle transmission, which is myasthenia, you should not be using Botox. But the small amounts that we use are really not going to harm these patients if there is a proper indication. I have a myasthenia patient who has hemifacial spasm. So he comes for Botox to me and he takes his myasthenia treatment from the neurologist. So it's all relative. Locally, I would avoid injecting if there has been a recent infection or maybe a surgery. Definitely fillers closer to a surgery is not a good idea because it will get absorbed faster. Any kind of pustule or signs of recent infection which is clearing off, I would wait until I give the injection.
And sir, if the patient is concurrently like having some dermatology treatment also, like for the pigmentation?
Surface treatments is not a problem, like lasers, for example, which are fractionated, or they're having peels. You could just do the Botox, and once you've injected the drug, within less than an hour, the drug gets into the muscle. And after that, you can have whatever skin treatment that you want to have, of course, with aseptic precautions.
Okay, sir. Sir, when we're talking about risk of arterial embolization, sir, is there anything that we can do to reverse it, like hyaluronidase or any enzyme like that, that helps to reverse the like accidentally injected filler in the artery or something?
There is research going on this topic, and there you can find a lot of articles which talk about retrobulbar hyaluronidase injection, particularly in dermatology literature. You will even find kits and advices as to what to do in this situation. None of these have worked. There's no evidence that they work. And there are some very interesting animal and in vitro studies which have shown that this really is not helpful. The drug is not reaching where you want it to reach, which is intraocular into that artery where the embolus is. My gut feeling is that unless you give it intravitreally, it's not going to work in these patients. But you can do certain things to prevent it. So you can use a cannula instead of a needle, although that involves making a small opening, going in, and it's not as easy as a needle, but cannula is blunt and it avoids poking a vessel. Secondly, inject very slowly, always confirm by aspiration before the injection. It's easier to say than do because when you aspirate, a bubble comes in and that complicates the rest of your treatment. Slow injection, aspiration, also making sure by palpation and visualization that your drug is going into the soft tissue and not disappearing into a vessel. So these are all ways and means by which you can prevent it. Cure, if anyone finds a cure for it, Nobel Prize is waiting.
Yes, sir. Someone interesting question is, can you please explain in brief about brow inking? That is, I think, permanent tattooing. What all precautions needs to be taken?
Well, microblading or micropigmentation, that's called as. You don't need any precautions. I think these are done by many non-doctors, some of the glorified parlors, they do it. It's a good way to hide some inconsistencies in the brow, maybe scars or patches where there is loss of hair. There are no precautions before or after that. It's just a straightforward treatment.
So next one is how to calculate the amount of filler that is required. Like how much are we injecting? Is it
But
totally?
there's no mathematics involved in it. Your goal, if you look at this picture again, I wrote the same thing again. You can see that there's a depression here, and you want to make it all flat, in line with the cheek down below and in line with the orbicularis roll up there. So most patients, if you are able to buy 1 ml of filler, you should be able to treat both the teardrops. In about 80% of patients, you should be able to do it within 1 ml of filler. There are very few who would need more than one because their teardrop is that deep. And there are some where you could inject it fully and you would still have 0.2 or 0.3 ml. So I don't think there is any mathematics involved or volume calculation, just like how you do for orbital fractures. But as long as you fill up the tear trough and it looks clean like this treatment is not entirely science. It's a mix of science and art, and that's the reason why you'll always find some non-doctors, controversial people doing these treatments, but doing it very well. They know what they are doing. They may not know the science much, but they have the knack and the eye to see what is needed, and they do it.
So another question is like how we instruct the icing before the Botox injection. Is it required even before the fillers when we put in the fillers? Like we put the ice on the skin for vasoconstriction and.
Ice is primarily used to reduce the pain, and you could do the same by applying Pilox. You could also reduce the pain by just tapping at the time of injection. I find the ice thing to be very cumbersome. It's almost always not available, and once you start applying it, it starts trickling the water. It's a little messy. Most patients who want Botox, they are motivated enough to accept a little bit of those mosquito bites. And I haven't really seen a patient who's creating so much fuss to look better.
And so post injection, anything that needs to be instructed to the patient, like not to rub?
After the injection?
Yes,
well,
sir.
Well, the insert of the toxin vials, they mention that you should not be doing heavy physical activity for 24 to 48 hours. And there's also a weird explanation why they should not be lying down for 4 hours after the injection. Apparently, gravity can take that drug back inside and block your extraocular muscles and cause liquidity as the theory. I've never seen that in a patient, but probably makes biological sense to do that. No one goes and sleeps anyways immediately after the injection. So apart from that, yeah, pretty much not to have the regular or tap water maybe to use and wash the face immediately after injection, because your pokes with the needle, they're still active. They can still theoretically take bacteria in. So giving it a day, just light work, and then getting back to your routine activities.
Spoken about one case where you had given it retrobulbar for volume augmentation, but
Right.
like they are temporary measure. So
Yeah.
we need to like repeat it on a regular basis.
Well, that particular patient never came back for another injection. I was not aware why she wanted it so badly at that time for this weird indication. Yes, she was sunken, but her pre-ops looked pretty much like many of us who have a certain low value of hurdles. Obviously, in these patients, other options or more long-lasting options would include implants into the orbit where you want to build volume. But personally, I tend to dissuade them because I just feel that the risk completely outweighs the benefits there.
And so, like, what is the role of imaging in cases of like BEB and or hemifacial spasm before we go on to give the Botox? Like
Well, for
neuroimaging.
BEB, it's practically of no use because BEB is predominantly a functional nerve disorder. So you're unlikely to find anything in imaging. HFS, yes, because something is irritating the seventh nerve along its path. So although the commonest reason is a vascular loop, uncommonly you could have tumors sitting which are bothering you. So if a HFS patient has never done an imaging, I would do that, particularly if they are young and also if they have auditory deficits because the eighth nerve is pretty close. But apart from that, for BEB, I don't find any medical reason to do it. Maybe a legal reason to just be safe and say that I've imaged.
So would you send all the, like suppose a patient of BEB or hemifacial spasm comes to you as like the first visit. So
Right.
would you send all these patients to the neurologist, or do you, like once we diagnose, should they have like a neurology checkup, all of them, or should we go about it?
Well, scientifically, I would have done that, just like how we would have sent a watering patient to INT colleagues to check the nose. But what do they end up doing is endo-DCR. So, and the same is done by the neurologist. They give the Botox, and I would have been happy if they gave it in the right locations, but usually they inject right into the brow, the areas that we are supposed to avoid to cause ptosis. So I don't send them to the neurologist. I tell the patient that, oral medications is one of the options apart from botulinum toxin. And if you want to try it out, you can visit a neurologist. And if you are wanting to have the injection, I can provide it.
So I think I'll just take the last question. In post-traumatic depressed scar tissue, can fillers be injected below it to reform the contour?
Yes, it can be. You will have to try out in one particular area to see whether it really lifts. So some of these depressed scars, particularly linear ones, are best revised rather than putting fat or filler beneath it. But if there's a more generalized depression, let's say a depressed localized frontal bone fracture, you just want to elevate it, filler is a good option. Fat is also a good option. Similarly, getting in surgically and doing the actual bony work is also an option. But filler is the least damaging and the easiest.
I think so. We have covered most of the questions for the day. Thank you so much again, sir. I think like it's a super specialized topic, but you made it so simple for our residents also. Definitely enjoyable for all of us here, all the fellows here. We learned so.
Thank you very much, sir. It was a wonderful, wonderful presentation.
Thank you so much.
And it was a pleasure.
So just for, if I can just ask one last question.
Yeah,
most of the patients who are coming for these procedures, they're generally quite motivated. But
right.
Are there any patients that you as the doctor would like to dissuade or say, try to demotivate them for the procedure?
Yeah, there are many. And commonest examples are the ones who really are not sure what they want, but they just read something on the net. And you will generally be able to guess them. They'll just randomly throw some, treatment titles at you, almond eye, fox eye, and they'll interchangeably use the indications for Botox versus filler. That is one. The other is those who have unrealistic expectations, those who say that, you can inject, but you cannot give me a bruise. So if someone really confuses whether I am a surgeon or a magician, I just avoid that patient because it's only going to make both parties unhappy. So they have to understand that there are certain downsides, and this is different from just a visit to the parlor. This is a medical process which can have complications, benefits too, but you have to take certain risks for them.
Thank you, sir.
Okay. Thank you so much. Thank you, everyone. It was a
Thank you,
pleasure.
sir.
Thank you, sir.
Sparing your time to be with us today. Thank you, sir. Good night.